So I was assigned to talk about liver transplant in a certain area in Europe. Europe is difficult to define areas in many regards. Therefore, I tried to present the data related to the access I had to those data, and in a group of former communist countries with somehow similar problems. And sometimes with similar solutions. So this presentation, but finally I will focus mainly on Romania and on the Romanian program, since I know this much better than the others. As you know, liver transplant it's a big industry today, and as it has been shown before, is the victim of its own success, since the waiting lists are always bigger than the potential to transplants of probably all the countries in the world. So in Eastern Europe, we started late compared to others. You have seen before that Brazil started in the 70s or 80s anyway. Here in Eastern Europe, Poland was actually starting before 1990. All the other programs started after 1990, some of them after 2000. Here we can see this compared to other European countries. So here is Poland, started in 1987, and then all the others. Now in Europe, about close to 7,000 operations of liver transplants are performed each year. And in this European group of countries, those countries in Eastern Europe are included. We'll see with their particularities. Indications are similar. So these are indications at the European level with the countries that I will analyze: Romania, Poland, Hungary, Bulgaria, Croatia, with similar indications also in their national programs. Survival also from the European Liver Transplant Registry. It was presented also earlier by many other speakers. As we can see, the best survival is in program transplantation for chronic cirrhosis with worse outcome in acute liver failure and in cancer patients. The particularities of the region that I analyzed, so these are all developing countries. Some of them lack appropriate organization, so they need legislation, they need public awareness, they need education, they need motivation for organ donation. In the beginning, it was a small number of well-trained transplantations people, surgeons, anesthesiologists, gastroenterologists, etc. And in the area, there are some regional cultural conflicts with some impact on the transplantation business. So, how to improve the modalities? The implementation of specific legislation is necessary. The development of national transplantation network is also necessary, including the coordinators, the procurement centers, a transplantation team, and listing patients on waiting list. Public awareness was a huge effort in the area to educate the population to accept the donation, to solve the religious and cultural issues, and to use the mass media. Mass media actually was extremely helpful. I would strongly recommend for people, including Egypt, trying to introduce brain death and to ask for the help of the media, because this is crucial. Professional training and financial resources were also important. So in 2009, there was this paper about evolution of indications and results of liver transplantation in Europe. This was a report from the European Liver Transplant Registry, and we can see, so while France has 16,000 transplants and Spain 15, here in the Eastern Europe area, Poland was the front runner with 1,400 transplantation, and then with less transplantation was Hungary, Romania, Serbia. At the time, I think Croatia was not even on the map, and we'll see, because they exploded lately with a very good program of organ donation, particularly cadaveric organ donation. The regional trends. So the population in the area, it's very small in Moldova 3.5 million, pretty big in Poland and Ukraine. around 40 million or a bit more. We see here the population. So these are the countries with the largest population in the area. These are is the number of centers. Number of centers is not relevant. So from the Brazilian experience, I got the idea that maybe there are too many centers and the small centers should not exist. Actually, maybe Italy has the tendency now to reduce the number of centers, favoring the centers with experience where the results, of course, could be better. Therefore, the fact that some countries have, like Bulgaria, 4 centers, I wonder if this is a good or not thing, but anyway, it's a national option. The donation rate in the area. So here we see the champion is Croatia by far now. They have one of the best donation rate in the world, so 34.8. While so Hungary, Poland, and Slovakia are in the usual range of 12 to 14%. So the success of the Croatian model, it's very easy because, as it has been shown earlier, most of the donors are lost in the ICU. So the Croatian realized this thing, and more than educate people, Yaman, in the ICU, is better to pay them. It makes a difference. Please believe me, for sure. To the point, I mean, paying means also salaries for the 2 categories, transplant coordinator and so-called key donation person, the person responsible for the donation process in the hospital. If you pay them, it makes a difference. And also you have to provide financial resources to keep the donors in good condition. To the point that sometimes, at least in Romania, in some ICUs, they have more financing for the dead people, which are the donors, than for the alive people that they are supposed to save. But actually, if someone wants to have donors, have to include the financial aspects in the effort. So the liver transplant waiting list has grown continuously over the past decade, and also the mortality on the waiting list increased, the time on the waiting list, and here are the figures. So this is normal because, as I mentioned, the transplant is a victim of its own success, and also in this area, some strategies should be imagined in order to reduce this. The number of procedures, the total number, Poland is the front runner with more than 300 transplants per year. They have 6 centers. And then Croatia, these are data up to 2012 was the last year when the data were available from the whole region. Croatia more than 100. Romania, the last figure 2012 was 75. Hungary was 40 and 41. Per million, we can see Croatia, it's even better, so it's by far the front runner because they have only 5 million people, and this is the number of transplantation per million. And all the others trying to improve their national figures. Again, Poland, it's a landmark in the area with between 7 and 8 transplants per million. There is disease donation and living donation in the area. Disease donation, all the countries involved, and I mentioned the figures earlier. With living donation, particularly Poland and Romania try to promote this type of donation in pediatric and adults. And also, this is a situation in pediatrics. Poland has the largest program. Also, Romania, Hungary, and Croatia trying to improve annually the pediatric programs. Split, also it's promoted in some of those countries, not many operations, as we can see, 5 in Croatia. These are data from 2011 and 2012, 4 in Romania, 2 in Poland. And now I'll focus on the Romanian program. We started in 1997, some landmarks regarding the operations and some regarding the legislation and financing of the program. They are not really important, and I will come back on some of them. This is the number of the patients on the waiting list. So currently in 2012, we had more than 400 patients for a country of 20 millions. And the number increases each year. Therefore, we have to imagine some strategies to match this increasing number. And I will remind them briefly. So using the marginal donors, so now it's almost the rule to use the marginal donors. That means age donors, extended criteria that are very well known at international level. Still is taking some risk for the recipients, and I will tell you what do we do in order to minimize this risk. We try to promote living-related transplantation. We did even a dual graft. We try to promote split liver transplantation, and we did even one domino that Yaman knows very well because he did also some and he didn't report them. So is the marginal donors. Lately, the proportion, it's up to almost 20% of the cadaveric donors, but again, this is a good strategy because otherwise we will lose many organs, as you can see. What we do in order to minimize the risk, we do two things. So we choose usually recipients with low MELD or pretty low, and these are cancer patients, most of them, and we speed up as much as possible with the operation. So we aim always cold ischemia time less than 6 hours and warm ischemia time less than 1 hour, including the artery. So therefore, I think using those two things we can minimize the risk for the recipient. So, and we try to diversify the procedures, as I mentioned. Still whole cadaveric liver transplantation is the main procedure, but we are close to 100 living liver transplantation. We have 7 split operations, so with 14 recipients. We use also, as I mentioned, dual graft and domino liver transplantation in order to increase the number of transplanted people. Here, these are the indications in our program. They are not different. Unfortunately, in Romania, we still have a lot of hepatitis B, despite a national program of vaccination, but probably this is too recent to have effects. This is the number of transplantation procedures since we start actually after the first successful liver transplantation in 2000, so we increased constantly. And last year we performed 122 liver transplants. Was for the first time when we went beyond 100. The survival, here we can see it's a bit different, but not statistically significant between living-related and cadaveric. I mean, this is a good reason because there is no statistical significance. Still, we have to, we aim to improve the techniques and maybe the indications in living related in order to match perfectly the results in cadaveric. Here is the number of splits, so 7 for 14 recipients. As I mentioned, we split most of the time for an adult and a child in 4 cases, so 2 splits for 2 adults, which were of course not really big. This domino and this dual graft has a very special procedures for a special situation. Well, in conclusion, so regarding our program, we would like to have a reduction of dropout rate on the waiting list by shortening the time on this list. We'd like to provide liver grafts for urgent liver transplantation in cases of acute liver failure. We favor the living related in acute liver failure, and we perform once such an operation. So therefore, and we do 2 things. One, also, if there is an IBO incompatible, we apply the special protocol for incompatible and we proceed with the transplant. And if there is a donor in the family, we use it in acute liver failure or in emergency retransplantation. Also, a proper recipient selection to obtain best results after transplantation that I mentioned for the marginal donors. Other solution is to increase the number of deceased donors, so brain dead, and we consider non-heart beating. So we had, but just accidental non-heart beatings, that they just became non-heart beatings, not on purpose, but we decided to use them. The results were not so great, therefore we are very cautious, and honestly I'm not very optimistic with this category. It's allowed in Romania, but it's not the rule. But for the brain dead, I think a media campaign in order to promote donation and allocating, assigning key donation persons in every major hospital and paying them, I think makes a difference and can improve the number of cadaveric donors. Extended criteria, they prove to be an efficient strategy, because accepting these organs made a lot of difference in our program. Promoting living donor liver transplantation, I think it's a solution for both pediatrics and adults. Using some technical variant grafts, splitting more. Of course, when it's a perfect liver, I think it's most mandatory to split it today, but as has been shown earlier, not all the livers are splittable. The perfect livers, I think, should be always split. Sorry. And implementation of proper measures to increase the number of the deceased donors are mandatory. The use of extended criteria is efficient. Living related and split are nowadays standard procedures. Dual graft and domino are rare procedures, especially except here maybe, but whenever the case, I think they are recommended. Proper donor-recipient matching is the key for the optimal use of marginal and surgical variant grafts. And trying to characterize the area, regional area, Poland is the largest and most complex program in this area. Croatia is the best model for cadaveric donor. And once again, I emphasize this fact, the key point in the Croatian program is focusing on the ICU. And not allowing in the ICU to stop somewhere the process, keeping the donor to the point to get consent from the family. If you come to this point, most of the time you get consent. So Hungary has the same constant program, and Romania, as I mentioned, has an increasing program in a recent year. Thank you very much for your kind attention.